Hi again, everyone. I'm really sorry for that technical issue. For some reason, I was suddenly disconnected. However, it's actually good because it gives us some more time for more candidates actually to join us. I hope you're all able to hear me properly at the moment. First of all, I would like to welcome you all and to thank you very, very much for attending my session today. I hope you're all enjoy it. Second thing is, I wish you all good luck with your exams, with your PLAB-2 exam. Again, just a brief introduction about myself. My name is Dr. Khaled. I'm one of the doctors who are actually working in the NHS. I'm a GP registrar at the moment. I graduated in 2011. I've been doing medical work actually as a doctor. I've been doing, I did general surgery before, but I'm finally a GP registrar at the moment. I hope you're all doing great with your studies. And thank you very much again for attending my session today. Thank you very much. Right, so today I'm going to speak to you about the management plan. So management plan is a very important thing actually in your station, every single station in your exam. It's a very important thing to bear in your mind, how to tackle the management plan, how to win the management plan properly. So actually the management plan, you should score actually or it has got like 4 marks in the exam itself. So in order to score it properly, so there are some few tips actually that I would recommend in your stations or even while you're practicing for your PLAB-2 exam. So let's start now. Right, so general advice about the management plan structure, but as a whole, please give the management plan at least 2 to 3 minutes. It's so much tricky actually, and I have seen that with many candidates while we're doing this sort of mocks together. Unfortunately, some candidates don't pay attention to time. So please, whenever you hear the 6 minutes bell, please make sure that you are at least trying to start the management plan. It's a very important thing. Management plan is one of the things that actually, unfortunately, a lot of candidates don't really score much in it. Some people actually, for some reason, fail the exam because they don't pay much attention to the management plan. It's a very important thing in your station. Don't get me wrong, data gathering and also the interpersonal skills are really very important, but please try to make this balance between the 3 domains of it. So the management plan is a very important thing. Please give it time. If you are doing like we say, just the data gathering stations, so please give it at least 2 minutes time. It's a very important thing. If you're doing or if you're having a counseling station, because actually counseling station, you should pay more attention to the management plan, because in most of the cases, you might either know the diagnosis before you speak to the patient. So the main thing actually in the counseling plan, or sorry, in the counseling stations, to give at least 2.5 minutes for the management plan. You should speak more in the counseling station about the management plan. That's why it's called counseling. Right. So again, please avoid medical jargons. So medical jargons, again, a lot of people actually do it unwillingly, because actually you are a medical professional, you are a doctor, you used to even speak to your colleagues about the medical conditions, about the cases that you see every day. So you've got this habit of medical jargons. So please, as much as you can, try to avoid the medical jargons in your management plan. It's a very important thing. And even if you mention about a medical jargon, so please try to apologize to the patient and try to explain what you meant by a medical jargon. So it's a very important thing, bear that in your mind as well. Again, remember, it's a 2-way conversation. So it's between you and the patient. It's not a 1-way conversation. So it's not only you who is speaking to the patient and the patient shouldn't speak to you. No. So it's a 2-way conversation. Please assess the patient understanding while speaking to them. Give them some time to ask you if they have got some questions for you. So it's a very important thing to bear in mind. So it's a two-way conversation. The management plan is a very important thing. Management plan also includes further investigations if needed. If you do think this patient actually needs some further investigations, either by yourself or by the specialist, for example. So it's a very important thing to put that in your mind. So management plan is not only about treatment. It's not only about treating the patient's condition and that's it. No. So management plan actually consists of different things. We will go through them very shortly. However, bear that in your mind. If a patient needs further investigation, please try to mention that also in the management plan. So be patient-centered. The doctors actually who have attended my previous session, we spoke about how to be patient-centered, this sort of patient-centered approach. It's a very important thing to bear that in your mind. So by that I mean tailor the management plan according to the patient's needs, if possible. Not every single patient actually is able to go for an ultrasound scan. For example, they are unable, they are like wheelchair bound, for example, or bed bound. So you should find some sort of someone actually to help them if they are wheelchair bound, to help them to go for ultrasound scan. I'm just giving a sort of example. So not every single patient, you can apply the same management plan for everyone. However, put in your considerations that every single patient has got their own different circumstances. So put that in your mind. All right. So the management plan structure, actually, I'm going to speak to you about it, but hopefully this will be an interactive session today. So I might ask any of you doctors actually to, we can do like a session, a mock together, like a mock kind of station together, like a one-to-one station or two. So I would like you to participate as well. That would be really, really great. Right, so the management plan structure, actually, I have put that you don't have to follow it as a whole kind of thing, but you can bear that in your mind. You can apply that into your practice, your daily practice with your colleagues, and hopefully that will help you much to try to gain all what you can gain from the management plan actually before the 8 minutes bell rings. So it's a very important thing to bear in mind, to put that in your mind. So let's start by my management plan structure. Will make your life very easy, I promise. Right, so start your management plan actually by giving the patient the proper diagnosis. If you do think the patient has got a diagnosis, let's say like meningitis, let's say, I would say like migraine, for example. So if you do think this patient has got a diagnosis, if you're sure about it, it's called a provisional diagnosis, because no one is actually 100% sure about what the patient has got. But based on your clinical experience, based on the patient's symptoms, if you've offered them examination and if you've offered them investigations and the examiner gave you some sort of findings, so at that time you can say, okay, so I am thinking about that you might have got something, all right, this sort of diagnosis. Put that in your mind. So diagnosis is a very important thing to mention in the exam. Actually, once you pass all, I wish you all to pass the exam, and once you pass the exam, you will find in the marking sheet actually about the exam that there is a piece of thing which is called diagnosis. And if you don't mention about diagnosis, if you do think that this patient might have a diagnosis, so you unfortunately might be marked down. So bear that in your mind. Diagnosis is a very, very important thing. Please never omit it in your management plan. Right. Why I say diagnosis is a very important thing, or in another way, why I do say if you have got a diagnosis, because we are all human beings. Like I said, you might speak to a patient whom you're not 100% sure about what they have got. They might have got cancer, for example, but you're not sure if they have got cancer or not. So at that case, so please mention about the best case scenario and the worst case scenario. Mr. John, I do think that you might have got as simple as like a skin mole. However, I don't want to miss anything sinister. And unfortunately, by sinister, I mean like skin cancer, right? So give the best case scenario and the worst case scenario if you're not sure about the diagnosis itself, okay? But please try in most of the cases, if you do think that, no, this patient, I'm quite sure, I'm quite confident to diagnose them, so please give them a diagnosis. And like I said before, please try to explain that in a more layman language. Try to avoid medical jargons. Please explain the diagnosis properly. It's also a very important thing. So not only to give the diagnosis to the patient, but say, have you ever heard about that before? Do you like to hear about it? And then try to explain it in a very, very layman language. For example, if you do think that the patient has got a problem with their esophagus, so don't say esophagus, so say food pipe or gullet, right? Okay, so then try to give leaflets to your patient. Anybody knows why leaflets are very important? Please, if you know, shout out loud or even write that down in the comments. That should be great. Anyone knows why leaflets are really important, and a lot of people actually do like them in the UK?
Yes, my name is Dr. Emma. Leaflets are important because they give more information about the disease. Also, they can lead them to go to a support group, maybe some recommendations.
Absolutely, absolutely. Thanks so much, Dr. Emma. I totally appreciate your answers. That's really an ideal answer. Thanks very much. So leaflets, it's a very important thing because simply, actually, in most of the cases, when the patient goes home, he will unfortunately forget 90% of what you've told them today. They will even might forget about their diagnosis. So you mentioned to them they have got migraine and they have never heard about migraine before, right? So when they go home, they will actually forget about migraines, they will forget about the treatment. And this is actually a very, very true thing. This actually happens every single day. So leaflets, in a nutshell, you're actually giving the patient a diagnosis in a piece of paper. In addition, not only diagnosis, what does migraine mean? For example, if we're speaking about migraine, how to deal with migraine, how to avoid migraine, right? So leaflets are a very important thing because we are all human beings, we tend to forget, but if you give the patient leaflets when they go home, they will start to read about it again. And there is another important thing actually the leaflets can give you. Leaflets actually can avoid this sort of confusion, because if you do tell the patient you have got migraine, just imagine if this patient actually remembers migraine and starts Googling that at home. You can imagine what will happen. So patients, when they do Google things, unfortunately, they get shocked, they get surprised, they get wrong information in a lot of times. So please give leaflets. Leaflets are a well-trusted source. So it's a very important thing. So never forget about that. So always with every diagnosis, you please provide patient with leaflets. And the reason why I actually added that to the diagnosis kind of thing early on, because I don't want you to forget about leaflets. So normally when you do practice with your peers, with your colleagues, or even if you're having mocks, please at that time try to mention leaflets in addition to diagnosis. Makes life easier for the patient. At the same time, is actually a very good point the examiners like to hear from you. All right. Then the second point is, just think out loud. Shall I refer this patient? For example, if I am an FY2 doctor who is actually working in a GP practice, then shall I think about it? Shall I refer this patient into a specialist, or shall I discharge this patient home? Does this patient actually needs further investigations? So refer is a very important thing to put that in your mind. You are in the GP practice, for example, you have got your own limitations. The main idea about the GP actually is you can treat, if you're able to treat a patient, you can treat the patient. But if you're unable to treat this patient for a reason or two, if you haven't got the facility to treat this patient, at that time, please refer this patient. And the referral actually could be an urgent referral, a 2-week referral, or a routine referral, or even an emergency referral as well. So you can refer the patient if you do things that they have got like a life-threatening situation. You can refer this patient to the emergency department straight away. 2-week wait, actually, if you do think this patient has got cancer, routine referral is just a normal referral. The patient doesn't need to be seen immediately, straight away. Right, discharge home if you are happy for the patient to be treated, if you're happy to treat the patient at home, and then you can even offer follow-up later on. So it's a very important thing to put that in your mind. Do you like to refer the patient? Do you like to treat the patient? Or the patient might, not need any sort of further treatment, actually. Don't think that this patient needs treatment, but they might need some sort of reassurance. Right. If this patient needs further investigation, like we said earlier in the introduction, please, if you do think this patient needs further investigations, mention that, but avoid unnecessary investigations at the same time. Don't normally just, oh, if a patient has got migraine, I'd like to, or you do think this patient has got migraine, I'd like to offer you a CT scan. There is no point of offering a CT scan. Try to treat the patient first. If his treatment or if your sort of plan actually didn't suit the patient, so at that time you might refer the patient to a specialist. The specialist might be able to request like a CT scan for the patient and to follow them up if needed. All right, good. Right, Emily is asking if the patient has already diagnosed with migraine. Right, I didn't quite catch the meaning of this question. Sorry, Dr. Emily. If you like to speak out loud and just tell me what you mean by this question, sorry.
Hello, doctor.
Hello, hi, Dr. Emily. You're right.
Yeah, I'm fine, thank you.
Yeah.
Sometimes the patient is already diagnosed with a condition. So for referral, I don't know which case we need to refer and which case we don't need. For example, if this patient already knows that she or he has a migraine. So at this case, we need to change the medication or we have to refer.
So migraine itself actually should follow the guidelines about the migraine. As a GP or as an FY2 doctor who is working in a GP, this actually applies for every single thing in your life as a doctor here in the UK. We normally follow the guidelines. So the migraine, for example, if we want to treat migraine, if the patient tried paracetamol, didn't help, and then she tried something like ibuprofen, which didn't really help, again, we can offer something like sumatriptan. So sumatriptan, you can even offer that in the general practice. You can even offer that in the primary care. So sumatriptan, if that doesn't really help, we can try something different like aspirin, 900 milligrams. So if that all didn't help actually, then try to think, am I treating migraine? If I know this patient has got migraine, did I actually rule other causes of headaches? If I did really rule out all other causes of headaches, and again, I'm saying this because I have seen that a lot with many candidates, unfortunately. For example, if a patient comes to you with chest pain, and then he starts the recitation by saying, oh, doctor, my asthma is killing me. What your mind will process. Your mind, that's a trick, by the way. Your mind will process, I will ask every single question about asthma, but I will forget to ask about why this patient is here today. This patient actually presented to me today with chest pain, but he thinks he has got asthma because he's already diagnosed with asthma. But did I rule out all other causes of chest pain, all other causes of shortness of breath? Okay. The same situation applies to migraine. Have I ruled out every single reason behind headaches? Am I convinced that this patient actually has got migraine? If the patient has got migraine, and I do think he's got migraine or she has got migraine, did I treat them properly? If I treated them properly, but medication didn't really help, here it comes the time that you should refer this patient to specialist. You did all what you can for the patient, but this didn't really help. So now you refer the patient to specialist. Sorry, Dr. Emily, I just interrupted you, sorry.
It's okay. It depends on the severity of the condition and excluding the red flags.
Absolutely, absolutely. This is what I'm trying to say. You've already excluded every single reason or every red flag about headaches, about migraine, for example. And then now you do think that this patient has got migraine based on his history or her history, based on the examination, normal examination, for example, no neurological problems on examination. You did some sort of investigations, like routine bloods, like full blood count. This patient is not anemic. So you do think, you're really convinced that this patient has got migraine, or the patient has got migraine before, and this current attack of migraine actually mimics migraine he had in the past. So yes, I do think the patient has got migraine. At last, no problem. At last, you can actually safety net the patient if symptoms are getting really worse, if they've got any sort of neurological symptoms, such as any sort of arm weakness, leg weakness, blurring of vision, any dizziness. Please, at that time, seek urgent medical advice immediately by calling 999. Right? Thank you. I've got another question, which is, please, when does one give the provisional diagnosis? Is it after examination or after investigation? Thanks very much. So to give a provisional diagnosis is after examination, of course, because examination is a part of your data gathering. You're still gaining or gathering data about your patient. Examination is a part of your data gathering. You still don't know about what's happening with a patient until you examine them. It's a very important question, doctor. Thanks very, very much. Examination is a very important thing, actually. In most of the cases, you need to examine them even though you know the diagnosis, because you want to make sure that this patient actually hasn't got anything different or that their condition is not getting any worse. Examination is a very important thing, but bear in mind that actually belongs to data gathering. So when to mention about the diagnosis is after examining the patient, you might even think about or even ask about initial investigations. At that time, you make sure that, okay, I examined the patient, I have got very good idea about their situation. I also gained some sort of findings about my initial investigations. I'm quite convinced that this patient has got migraine, nothing more sinister. Okay, so diagnosis is after examining the patient, and you might offer initial investigations if you like, but that's after examining the patient straight away, then start your diagnosis. Thanks very much. Dr. Fawzi is asking, should we ask in patient what he wants to know about first? Like if he wants to talk about lifestyle management plan first. Right, I do got what you meant, Dr. Fawzi. So I will just speak about that in detail, but the problem is you've only got 2 minutes in the exam to speak about your management plan. There is no more time, actually, not fancy, giving the patient more and more and more options, actually, and the patient thinks about them. This actually takes and consumes some time. So you can ask about is the patient, if they are actually happy to know about their diagnosis, this is absolutely fine. But you can also ask the patient if they would like to know about the further management options that you can offer to them, but not with every single step. This will actually delay you in the exam. This will actually wouldn't be enough for you to complete the management plan in 8 minutes. So, for example, I'm saying that, I mean, when it comes to the practical kind of thing, we will possibly understand that better. So, for example, here, diagnosis. Do you like to hear about your diagnosis? Okay, so I have explained that in detail. Do you like me to give you some leaflets? Right. For example, do you like? I would prefer to refer you into a specialist in order to do 1, 2, 3, 4, 5. Is that all right? That's totally fine. But don't actually give this sort of opportunity about to ask the patient about what they would like to hear about first. The only other thing I would say, and listen to this very important thing, if you would like to tell the patient about the lifestyle management first, so let's imagine this. You have got 2 minutes left to speak about your management plan. Then you ask the patient, would you like to hear about the lifestyle? We have got 2 kind of options to offer you, either medical treatment or the lifestyle treatment, or we can offer you both. But what would you like me to speak about first? If the patient, imagine the patient asks, doctor, can you please offer me the lifestyle changes first? Then what will happen is you will speak about the lifestyle changes. Imagine this patient is a smoker who drinks like 20 units of alcohol a week. At the same time, their diet is not really good at all. You do things that they are not leading a healthy lifestyle. And then you start your management plan by telling the patient about how great they would be actually if they do change their lifestyle habits. What will happen is you will omit a lot of important things in your management plan. You will omit the symptomatic treatment, the definitive treatment. You might not find any time to speak about the safety netting, which is a very vital thing actually in your management plan. You might not even able to offer a follow-up appointment for your patient. So lifestyle is a very important thing, but the main thing is to prioritize your management plan. Put that in your mind, first things first. It's a very important thing. All right. Dr. Zara is asking, some scenarios we don't give diagnosis even after history and examination, like viral encephalitis. We have to do investigations first, then what we will say, like do lumbar puncture. It's all depends on what you do things. So if you do things, this patient, if you are in a GP setting, you do think this patient actually has got encephalitis, patient should go to the hospital straight away. Right? If the patient actually is drowsy, if they are not able actually to like communicate with you, if they are like comatose, for example, if they've got decreased conscious level at that time, you cannot actually mention that to the patient, but you can mention that to the next of kin. You do think this patient has got viral encephalitis, we have to do investigations first. Then what we will say, like I said, it depends on your setting. If you are in the hospital, you do some routine bloods first, and then sometimes the lumbar puncture actually cannot do it until you rule out this patient hasn't got brain edema, because lumbar puncture is actually contraindicated in brain edema. So you can offer a CT scan first and then see this patient hasn't got encephalitis, or this patient has got, you do think this patient has got encephalitis, but they haven't got brain edema at that time. Yes, you can offer lumbar puncture if the patient is aware, if the patient is awake actually and you're speaking to them. All right. I hope this answered your question, Dr. Zara. Okay, right. Then think about this. You are an FY2 doctor who actually works in a GP, you work in the hospital, you work in the department itself. So it's a very important thing to put that in your mind. What are you doing here? What's your role here? It's a very important thing. Never forget about senior discussion. And the way you can mention that to the patient is, shall I mention to the patient, I'm not sure, I'll have to ask my senior first. How do you find this, doctors? I am an FY2 doctor who has just seen a patient. And then when it comes to the management plan, I will say, Mr. John, unfortunately, I'm not sure about what's happening with you at the moment. However, I'll go and speak to my senior and let you know about what they do think. So you are an FY2 doctor. What will the patient think? What will the examiner think? Will it seem safe, doctor? Okay, thanks very much, Dr. Emilia. Right. So in another way, I am saying, do you think that I am too much confident, or I am not confident about my diagnosis. So safe doctor is absolutely right. However, this doesn't actually need to happen in every single station. It only happens if you're not 100%, you don't know what's happening with this patient actually. And this shouldn't be the case in every single station. You should be confident. Dr. Ahmed Youssef is actually saying not confident. Exactly, this is what I meant. You will not seem very confident with your diagnosis. Senior discussion is a very important thing. After you see every single patient, you should discuss this patient, but it doesn't necessarily mean that you don't know what's happening with them. So you should have your own identity in the exam. You should be confident with what you've got. You know, you've got the medical experience that you do think this patient has got migraine, but they haven't got cancer. You don't think that they have got cancer. However, you would like to discuss that with your senior. You're confident about diagnosis, you're confident about the management plan, but just as a safe, being a safe doctor, you will discuss that with your senior as well. But never say, I'm not sure about that. I will go and speak to my senior. You can still say that, but not in every single station. You can say that if you don't know actually what's happening with this patient, you don't know what's happening at all, but never use this a lot. This will seem as if you are lack of confidence. Dr. Ivan, sorry if I'm not pronouncing the name right. Should we discuss with a senior in all scenarios? Absolutely fine. This is actually how you can be safe. Because imagine you do think a patient, you're very confident a patient has got migraine. However, when you speak out loud to your senior and say, oh, I do think that this patient has got migraine, but the senior might have got an extra more important questions that you might forget to ask the patient about. For example, did you ask the patient, how did this pain start? Did it start suddenly? Did it start gradually? Is it the worst pain you've ever had in your life? Where about this pain? For example, if you did everything, however, you forgot to ask about this, this might actually, or you might miss something like sentinel bleed or some subarachnoid hemorrhage. So what I'm saying here is you're confident about your diagnosis, you're confident about every single thing, but at the same time, the senior is a very important person actually that protects you, protects the patient. It's a very safe thing. That's why they are called seniors. Otherwise, you are not an FY2, you are just a consultant, for example. So the PLAB-2 is all about being an FY2 doctor, knowing your limitations, knowing that you've got a senior to discuss with just to make sure that you're not even missing anything. The senior has got more experience than you, so that's why you should discuss with your senior about what you do think this patient has got. But you still, at the same time, you are confident with what you've got. So you can imagine when you go to the senior and try to discuss with them, what will the senior ask you? The senior will ask you, what do you think is happening with this patient? And what's your management plan? Okay, so the senior will ask you, what do you think is happening with the patient? I have already discussed with my senior, and then I told him he's got like symptoms of migraine, and I didn't mention migraine to them. And then they will ask me, what do you think this patient has got? I'm not sure. At that time, also the senior will think that you haven't got confidence enough to be competent, actually, all right? So get your own identity in the management plan. You please be sure, be confident about what you've got. Even if you're not sure, I would say the worst case scenario, if you're not sure, what you can do is to tell the patient, I am not sure, it could be possibly something simple, or could be this diagnosis, or could be that diagnosis. So at that time, I would actually double check that with my senior, because it's a bit of a difficult situation at the moment. It's very hard to tell. I will speak to my senior and they might come over and have a look into you as well. This is the worst case scenario, but don't even only say, I'm sorry, I don't know what's happening. I will go and speak to my senior. This is not what the examiner actually, this is not what the GMC is waiting to hear from you. in every single station. All right. Thanks so much. Right. So now we know how we are going to speak about the senior in a confident way. Right. We are all welcome doctors. Then it comes to the symptomatic treatment, definitive treatment. I call it, by the way, I call it triple S, if you keep that in your mind. So senior symptomatic treatment safety netting, put that in your mind, triple S, senior symptomatic treatment safety netting. Right, when it comes to the symptomatic treatment, if you're confident to treat this patient symptoms, at the same time, if you do things that this patient has got a definitive treatment, so at that time, please offer that to the patient, right? Symptomatic treatment, patient has got pain, offer painkillers, patient has got sickness, offer anti-sickness medications, antiemetics. If you got a diagnosis and you do things that you can treat this patient, you've got a definitive treatment for this patient, please offer that to the patient. Safety netting, safety netting, safety netting. I'm saying that 3 times because it's a very, very important thing. Please, doctors, never end any conversation with your patient without safety netting. Anybody knows why? Anybody knows why safety netting is a very important thing?
Hello, Doctor.
Hello, is it Dr. Emily?
Yeah, safety net is very important for, I can say for all the conditions, because, for example, if you prescribe warfarin and the patient going home, come back with headache, or if the patient does not understand what is this headache and neglects, because a lot of, it may cause life-threatening condition.
Absolutely.
So, yeah.
Absolutely.
So, to be on
I
the
totally
safe
agree. Yeah, totally agree, Dr. Emily, with you. So safety netting is a very important thing. Being a safe doctor is a very important thing to mention about safety netting. So safety netting in a nutshell is the worst case scenarios that will happen to the patient. So please mention that to them. If you do think this patient has got migraine, I'm giving an example. So please mention if you've got any severe, if your pain is getting any worse, if you get any sort of arm weakness, leg weakness, slurring of speech, fast symptoms, please at that time seek urgent medical advice immediately. So you do think this patient has got migraine. However, we are all human beings. You mention to the patient he has got migraine, or you do think that they have got migraine based on your clinical experience, but there might be something different happening with them. That's why safety netting is a very important thing. Safety netting actually saves you as a doctor even before. I am always saying this because safety netting saves you actually, and it saves the patient at the same time. Why I'm saying this? Saves you actually because just imagine this patient has got a brain tumor. All of the symptoms mimic migraine. They come only on one side, okay? But you do think that they have got migraine. And a few weeks later, this patient situation got deteriorated and they discovered that this patient actually has got a brain tumor. This patient, after being diagnosed and after starting the treatment, actually, they will say, oh, this doctor actually has seen me, but he didn't even bother to refer me urgently into the specialist. I could have been treated properly if this doctor actually has referred me earlier to the specialist. The patient then decides to sue you, okay? Because they do things that you didn't give them the proper management. You didn't give them the proper treatment, okay? Or the proper referral. So safety netting is a very important thing. Safety netting, even in documentation, while after you've seen the patient, you document that you've seen the patient, you offer them safety netting. This actually will save you as well. If a patient says, oh, this doctor actually didn't diagnose me with a brain tumor. This doctor actually didn't think that I have got subarachnoid hemorrhage. But this doctor actually did give me safety netting advice. He mentioned to me, or she mentioned to me, if I get any arm weakness, any leg weakness, any blurring of vision, if I get any dizziness, please speak to 999 immediately because there might be a sinister thing that's actually going on. All right? Safety netting saves you before it saves the patient. Okay. Dr. Sorry? Yeah, that's all right.
For prescribing medication, for example, you prescribe metronidazole. It's important to tell the patient, don't take it with alcohol. If you tell the patient this, so the patient cannot complain. I have seen a patient on Ramipril for 1 month. He had a dry cough, but the doctor didn't tell him that this is a side effect. He was very worried about this.
Exactly. Let's imagine you've given a patient codeine, right? This patient actually works as a driver. Codeine actually causes dizziness and drowsiness. And this patient actually decided to take codeine before he starts his job. This patient has got drowsiness while he was driving, ended up by a major accident, and then you will be the one who will be blamed. If you give a medication that you do think that there is warning signs about its side effects, you please mention that to the patient. So I totally agree with you, Dr. Amged. Thanks so much. Yeah, that's really perfect. So safety netting is not all about only the patient's like medical conditions. So even if you do give a medication that you do think that this patient might gain harm from, for example, as a side effect. So side effects doesn't necessarily mean that they should happen, but they happen in some case scenarios. Okay, so you warn the patient that this medication actually can cause some sort of drowsiness, so please never take it if you do drive. Okay, so it's a very important thing to bear that in your mind. So safety netting is a wide spectrum kind of thing. It actually, like I said early on in the introduction, tailor your management plan according to the patient. I can't really speak in one session about every medication and what they do cause as a side effect. So tailor your management plan according to your patient. All right, thanks so much. Dr. Emma is saying these are the warning signs that patients should rush to the emergency or contact his doctor. Actually, this is, yes, this is safety netting, warning signs, red flags. So thanks so much, Dr. Emma. Follow-up. So follow-up, actually, that's also considered as a kind of continuity of care, as a patient-centered approach. You're not only telling the patient, okay, so take this medication, see you later, bye-bye. No. Some patients actually need to be followed up. It's a very important thing to put that in your mind. Follow the patient up. If you do think that this patient, you want to make sure that this patient is actually improving or the situation is actually getting worse. So follow-up is a very important thing. But if you do refer this patient into specialists because of a certain problem you do think they have got, at that time, the specialist actually will follow them up. Okay, so you don't have to offer a follow-up for the patient if you do think they have got like skin cancer. You have referred the patient in a 2-week wait, fast track referral into the specialist. The specialist is going to see them and start the management plan and follow up. You don't have to follow the patient up, but the specialist will. Last but not least, lifestyle advice. Lifestyle advice, like I said, is a very important thing. And it's also patient tailored based on what the patient has got in their lifestyle that needs to be adjusted according to the medical condition. For example, if a patient has got chest pain, but you are not in the emergency department, you are like in the GP ward, you are in the GP practice, and you've got a patient who has got chest pain and they do smoke, so please advise them not to smoke. You can even offer them to be referred into the smoking cessation clinic or the service itself of smoking cessation. If they do drink alcohol, the same thing applies. If they have got problems with their diet, actually, if they are eating unhealthy diet, so please offer them some help, and even you can refer them into a dietitian if needed. Why I actually mentioned that at last, at the bottom of this list, does it mean that the lifestyle advice is not even important? It's actually very, very important, but you can imagine if you start your management plan by telling the patient about what kind of advice you're giving them to stop smoking, to treat or to help with their diet problems and even alcohol. Okay, so at that time, actually, it will consume a lot of time, and you've got a list of other things that you would like to mention. However, if you do that at last, and if you even mention about one thing in the lifestyle advice, so that should be enough. But if the counseling station actually, if you are in a counseling station that actually speaks about something that needs to be adjusted in their lifestyle, like if the patient is actually obese patient and she would like to lose some weight. So here you will give more advice about the lifestyle kind of thing, if it's a counseling station. So that's why I'm telling you, doctors, and actually advising you to provide the counseling stations in the management part of it with more time, at least 2.5 to 3 minutes in the counseling stations. Compared to the data gathering stations, you don't have to give more than 2.5 minutes, I would say. You can even give more than that if you've got more time. That's absolutely fine, but don't stress yourself out. I should finish, I would say, the data gathering part in like 4 minutes or so. No, nobody can do that actually. It's a very tricky thing. All right. So again, just to summarize what I've said, so diagnosis, leaflets. So then start to think whether shall I refer this patient, shall I discharge this patient home, offer follow-up later on if needed. Does this patient actually need further investigations? Then senior symptomatic treatment, safety netting, offer follow-up for this patient, and lifestyle advice. Any questions at all, doctors? Has anyone got any questions at that stage?
Doctor, I have another question. Sometimes during the exam, the patient tells you why this happened to me.
Mm-hmm.
So I think
Absolutely.
It's important to explain the risk factors. And the risk factors are different from a patient to another.
Absolutely.
So do you think it's good to give lifestyle advice with this question that the patient asks? For example, if the patient is diabetic, why this happened to me? It's maybe because of having family history or being overweight.
If the patient actually asks you this question, should be addressed now. If I ask you this question now, so you can give this sort of advice to the patient at the same time, but if the patient doesn't actually offer you, doesn't actually ask you this question, it doesn't make sense if you want to mention that early on this station, in this management plan part. If the patient asks you why this doctor is happening to me. So diabetes is not only about food, is not only about lifestyle advice, but it's also got some sort of genetic kind of thing, family history kind of thing. Okay, so it depends on many things, depends on the patient, depends on the scenario of that. I mean, you're seeing in the exam, actually, every single patient is different. But if the patient asks you why I'm having this, why I'm having high blood pressure, it depends on many factors, including family history of high blood pressure, also in your lifestyle. But actually, there are some things that you can do that we can offer. So there is what we call modifiable risk factors, non-modifiable risk factors. Modifiable risk factors actually is factors that you can modify in order to live a better life, such as smoking, such as excessive alcohol drinking, such as poor diet. These are things that will actually might help with the management plan of high blood pressure. However, some people actually tend to find some sort of benefit from lifestyle advice, but not every single patient who tries lifestyle advice will actually be cured from high blood pressure. So if that's the case, so there might have not been any sort of medication to treat high blood pressure. So there is medication treatment, but it only depends on the patient, because there is different, scenarios. The patient might come with a high blood pressure. Lifestyle advice wouldn't actually do anything for them. The patient who's got like mild high blood pressure or mildly elevated blood pressure, so at that time, lifestyle advice might help him. Right, so like I said, tailor your station with every single thing. This actually, management plan is a very, very important thing you can follow. However, let's think a patient hasn't got a lifestyle advice, hasn't got any problems with their lifestyle, so you don't have to mention this. patient whom you think doesn't need follow-up, you don't have to mention this. So the reason behind this sort of structure is actually to help you for your time management, structures that in your station, structures that in your daily practice with your colleagues in your mind. Okay, so when it comes to the management plan, I will ask about 1, 2, 3, 4, 5, 6. However, I would just tailor that. Does this patient need a follow-up? No, I don't think this patient needs follow-up. Or yes, I do think that this patient needs to be followed up to make sure that he's improving or they're getting better, not getting worse. Does this patient have got any lifestyle advice? No, he hasn't got or she hasn't got any problems. They don't smoke, they don't drink alcohol, for example, or even if they have got a lifestyle kind of things that's actually not really relevant to what is, if they do drink alcohol, it's excessive alcohol, it's fine to tell the patient that they should reduce alcohol drinking or cut down the alcohol drinking. But do you think that's actually relevant to the station? The patient presents to you in the emergency department with chest pain, and they do drink alcohol. You ask them about alcohol anyway. They mention, oh, doctor, I drink alcohol excessively. Okay, so do you think it's relevant now in the emergency department to speak about alcohol? Okay, right. Thanks very much, Dr. Emily. Okay, so let's agree that you please tailor your management plan into the patient, and this structure actually is to help you tackle the management plan, hopefully in 2 to 2.5 minutes in your management plan in the data gathering part, and the counseling station, please give it at least 2.5 minutes to 3 minutes to speak about it. Perfect. Right. So we have got an example now. We have got a station now. If you like, and anyone is like actually to participate, just raise your hand or even write in the comments, and I will choose the first one who's actually would like to participate. So an example where you are in an FY2 doctor in the GP practice. Who the patient is? Jane, 27 years old patient, present to you today with nasal symptoms. What you should do, speak to the patient, address his concerns or her concerns, sorry, and speak about your management plan. So Dr. Iman, or Iman, sorry, I'm really sorry, I can't really pronounce.
Yeah,
Iman. Hi, Dr. Iman, how are you doing? You're right.
I'm fine.
Yeah.
Thank you for the opportunity, doctor.
No, it's absolutely fine. It's my pleasure. And I'm really sorry if I didn't pronounce the name correctly,
No,
but
no, it was fine, the first one. It's Iman, yeah, thank you.
it's Iman. All right, perfect. Do you mind if I ask you, where are you originally from, Dr. Iman?
I'm from Algeria.
Oh, are you from Algeria? Yeah, it's really my pleasure actually to speak to you. And where is your exam? When is your exam?
The 1st of December, kind of soon.
Yeah, we still have got good time before it. Right, so how's your preparation? Do you find it really nice?
It's going, that's fine.
It'll be all right, don't worry. As long as you're doing your best, so it will be fine, don't worry. Yes.
Thank
so
you.
First of all, no, it's all right. It's all right. Are you able to hear me properly at the moment?
Yeah. How about you?
I'm able to hear you very, very properly. So do you like me to give you like a minute and a half to read this sort of stem, and then we can start our practicing?
Okay, let's just start. It's like
we can start.
Yeah.
That's really fine. I will do the GMC timer kind of thing, this sort of bell. If you're not able to hear it, just tell me. But if you hear it, just go for it straight away. All right?
Okay. Yeah.
Good. Okay. Begin.
Bougazi Iman, GMC number 12345. Good morning, Jane.
Good morning.
So I'm Dr. Iman. I'm one of the doctors here. Would you confirm just your full name and age, please?
My name is Jane Whitehead, and I am 27 years old.
Okay, nice to meet you, Jane.
Nice to meet you too, doctor. Thank you.
Thank you. So how can I help you today, Jane?
So basically, I've got some nose symptoms actually that's been ongoing for almost like a few weeks time.
Mm-hmm.
I have got some sort of pressure around my nose, on both sides. I also have tried some sort of medication, over-the-counter medications, like, you know, the sort of nasal drops, which unfortunately helped in the first few days, but it didn't tend to help later on. This actually annoys me. I don't know what's happening with me. I started to get worried.
Yeah, I can imagine. So you told me it started like a few weeks ago. Am I right?
Yeah, you are.
Yes. Do you remember any particular thing that maybe triggers these symptoms?
No, honestly not. I can't really think of anything.
Okay, so you didn't move the house, didn't bring like new things in the apartment, nothing like that?
No, not really.
Okay, so you told me that you have some pain on your cheeks. Like, am I right? So
some pressure symptoms around my cheeks. Yeah, this sort of, yeah, you know, discomfort.
Discomfort in your nose and cheeks. Okay, so is there any like discharge from your nose? Like
no, not really.
any,
No.
Nothing. Okay,
No.
so you feel just the pressure, and when you touch it, is it worse?
Yeah, I mean, when I do press on it, I think it's really tender sometimes. I don't know, it's anything to do with my nose. I'm not sure.
Yeah, but okay, but no discharge. So
No.
do you had any like flu-like symptoms recently?
No, I only have got some sort of blocked nose.
Okay, okay. So how about your eyes? Is there any particular symptom?
The only thing I get is sometimes some sort of pain behind my eyes in addition to this sort of pressure symptoms.
Okay, okay, I see. So is there any change in your voice recently?
No, I don't think so, no.
No, any redness in your cheeks? Nothing like that?
No.
Okay. So did you have this before, these symptoms before?
No, I don't think it's happened before. It's just my first time.
So anything else with all of this?
No, not really.
So, okay, so no headache?
Sometimes I get a lot of pain around this area as well, but I'm not sure if it's headache or is it related.
Okay, I see. So no fever?
No.
No, okay. No, nothing else, no change in your weight recently? Nothing like
No,
this?
not really. No.
Okay, so I'd like to know a little bit about you, about you, Jane. So do you have any medical condition?
Not that I'm aware of, no.
Okay, so no allergies?
No, not really.
Okay, so you told me you tried an over-the-counter medication. Yeah, what was that?
So like I said, I tried some sort of Otriven, laser drops. I tried also some sort of cetirizine, you know, the antihistamines.
Yeah. Didn't really help.
They did help in the early few days, but later on they didn't.
But then it got worse. So is there any particular thing you feel like makes it worse?
No, can't think of anything.
No, okay, nothing but it makes it better.
I don't think so.
Between like going out and staying in the house, where do you feel it's like the most bothering?
When I go out of my home.
When you go out, okay. So with whom do you live, Jane?
I live with my partner.
Okay, so does your partner have the same symptoms?
No, I don't think so, no.
No, okay. So what do you do for a living, Jane?
I'm a teacher.
Ah, that's wonderful. That's good. My mother is a teacher too.
Oh, I see. Good.
Yeah. So did you have any pregnancies in the past, Jane?
Sorry, say that again?
Did you have any pregnancies in the past?
No, I've never fallen pregnant.
Okay, so are your periods regular?
They are, yeah.
Yeah, you have no problem with that?
I don't think so, no.
No. Are you taking any pills?
Just the cetirizine, like I said, the sort of antihistamines.
Okay, so you don't take any contraception, Jane?
No, because I'm on a same-sex relationship, so I don't have to.
Okay, so your partner is a female. I see. Sorry if I didn't ask that.
That's all right.
Yeah.
Okay.
Yeah. Okay. So have you done your pap smear at 25 years old?
Yeah, I did, and was normal.
Yeah, that's good. So do you smoke, Jane?
No, I have never smoked before.
How about alcohol?
Just very occasionally.
Okay, so do you think there's a similar condition in your family, like allergies condition in your family?
I think my mom got asthma, but I don't think it's something relevant in here. Yeah.
Okay. So do you have any pets in the house?
No, not really.
No. Okay. So, Jane, do you have any idea what may be causing this?
No great idea, doctor. I'm sorry.
Any particular thing you're worried about?
I just wanted to know, have I got anything sinister going on with me at the moment? Because it's the first time actually to face such a problem.
Yeah, I understand. So is there any particular thing you're expecting from me?
Just if you could offer any sort of better treatment, I would be grateful.
Yeah, sure. Yeah,
More
sure.
than-
I will do
yeah.
that.
So 2 minutes remaining. We're now,
Okay, so
yeah.
okay, so I'd like just to examine you to do a nasoscopy. I'd like to see under your in your nose to see if there is any polyp, any discharge, any redness.
Yes, that's
Okay,
absolutely fine.
Yeah, I'd like to examine your your face, and I'd like to palp on your cheeks to see if there's any tenderness or any masses. Okay.
So examiner, the patient has got some tenderness around both of her cheeks. Yeah.
Okay. So Jane, I'm suspecting that you have what we call sinusitis. Have you ever heard about it?
No, not really, doctor.
Well, actually, is a condition where we have on upper of our cheeks something we call sinus. So when they got inflamed because of an allergy or a viral infection or anything like this, it causes these symptoms. You know, this what you are feeling like fullness, like this pressure. And for that, I'd like to ask for some investigation. We'll do an X-ray to see them. And I'd like to call my senior so he can get a look at you. And we will refer you to an ENT. So he make like further investigations. Are you with me, Jane?
Yes, I am. Yeah.
Okay, so it may be allergic. So for that, meanwhile, you can I can give you some antihistamine to take them for at least a few weeks. Okay, and it's good to keep a diary. You know, like to mention when you feel it worse, so we can like get an idea about the triggers. Do you think you can do that, Jane?
Move on to the next station. Thanks very much, Dr. Iman.
Thank you.
No problem. How do you think it went?
A long history.
Yes.
Yeah.
You nailed it. You nailed it. You know what happened.
Long history.
Long. So the second question I will ask myself is, long history I did take, but was it all relevant to this scenario? Was it all relevant to this patient?
Naturally.
To this patient. So 4 P's. All right. With a patient, you do think they might have got sinusitis. I always think how relevant this is to this patient.
Like the fact that I forgot to ask about the partner, male or female, so I thought I had to exclude pregnancy, but if I asked already, I think that would be irrelevant.
Why do I have to exclude pregnancy in this patient?
Before giving because before giving antihistamine.
There are some antihistamines that are actually allowed in pregnancy, so there is no problem.
Okay.
Yeah. So first of all, thanks very much, Dr. Iman. It was nice station. There's just some few tips that we're going to speak about in this station. So data gathering part was really nice, but at the same time, always think whether this is actually relevant to this patient or not. So take your data, try to figure out what's happening with this patient. When did that start? How did that start? The odd-para kind of thing, this sort of symptoms that the patient is having. Has she got any discharge, like you mentioned to me, which was really nice? Does she get any sort of blocked nose? The patient mentioned to you that she's already been trying some sort of over-the-counter medications like Otrivin, like nasal saline, like some sort of antihistamines as well. So she mentions that to you, but again, listening to the patient carefully is a very important thing. The patient mentioned she's already taking some sort of medications to try to help with her symptoms, but didn't really help. And again, you asked me, did you try anything for it? So active listening, listen to the patient very carefully. She mentions that to you, all right? Yes. So it's a very important to ask myself, I know that she's a female patient, but why do I have to ask her about sexual history, or why do I have to ask about her periods? At the same time, you did actually, because I intended to say I'm on a same-sex relationship, actually to confuse you. Okay, you can find this in the exam, definitely 100%. All right, because actually you didn't have to ask about this from the early beginning. Okay, so this actually wasted your time, Okay, so only ask about the relevant history.
Excuse me, Doctor. We usually have this idea that if it's a female, have to ask about 4Ps. Like,
I know.
It's mandatory.
I know, Dr.
It's
it's completely wrong, because it actually depends on every single patient. If you do, if you do think a patient has got, like, I would say, like migraine, how that's actually relevant to her pregnancy. In some situations, actually, you should ask about 4Ps. If you do think this patient has got a sexual transmitted infection, like a pelvic inflammatory disease, for example, yes, you ask about this. It's absolutely fine. If you do think that you're going to give a medication to a patient that actually contraindicated in pregnancy, yes, you can ask about pregnancy. Okay, but you don't have to ask about the 4Ps in detail at that situation. However, if you do think a patient has got a sexually transmitted infection, ask about the 4Ps in detail. If you do think a patient actually has got a like polycystic ovarian syndrome, for example, ask about the 4Ps in detail. Okay, if she's taking actually contraceptive pills or not, because actually contraceptive pills helps with the symptoms of polycystic ovarian syndrome. Okay, so how relevant the questions are is a very important thing. And yeah, of course, you try to rule out any sort of red flags. Okay, so has this patient lost any weight, which was really fine. You ask about any discharge, any bleeding from the nose, we can also ask about that, which is absolutely fine. Did that happen before or not, which was also very nice of you to ask about. P2, always ask about that. Is a patient told you, oh, doctor, this happened before, and how was it treated? Did the treatment actually work with you or not? Okay, because if it happened before, if the patient actually tried a medication that did really help with them, if you do things that they've got the same problem, so at that time you offer them the same treatment, is absolutely fine. Maftosa kind of thing, medications, allergies, family history, and you asked about smoking and alcohol, which was really fine. Smoking, if a patient doesn't smoke, please try to praise them because they don't smoke, which is a very good thing. If they were smoking and they are trying to cut down, encourage them, give them the positive vibes and say, oh, that's a really good step. I totally appreciate that. That's really good for you. Okay, that's really nice. When it comes to the examination part, never forget about the observation signs. That's a very important thing. To make sure that this patient actually is not having a sort of infection. You did ask them about fever, but you didn't check their temperature. Okay. So we want to rule out any sort of infections that might be going on. In a different case scenario, you might ask me, what are you expecting from us today? And I would say, doctor, can you give me antibiotics, please? You don't know if this patient has got infection or not. How would you answer this question? You didn't check their temperature, you didn't check their vital signs, you didn't check anything. You don't think that they need antibiotics, but there is a sort of deferred prescription. So you can prescribe antibiotics, but the patient can take them in like 3-4 days time if symptoms are not getting any better. You're not saying no for the prescription for the antibiotics, but you might, if symptoms are not even getting, in another way, you can say, if symptoms are not getting any better in like a few days time, please let us know. And then we might think about antibiotics, okay? But in order to answer this question, you should get some sort of information about any patient that you're seeing, including the examination. Like I said, the examination is not only about to examine the patient part, but to check their vital signs, to do a head-to-toe examination, general examination, in addition to the specific examinations that you've got, which is like you want to examine the throat, you want to examine if they've got any lymph nodes in the neck, if they have got any sort of nasal issues, so you want to examine them if they have got any polyps, like you mentioned to me, Dr. Iman. Thanks so much. Then let's speak about our management plan. This is the main thing actually for today, isn't it? So the management plan, actually, you mentioned about sinusitis. You did really explain that, which was really, really nice. you can also give leaflets for the patient to read about sinusitis, which is,
Mhm.
yeah, I mean, I've just mentioned that today, so you haven't processed that in your mind, but
Yeah, I
hopefully
guess
this
it's
time, yeah, it will be fine. Don't worry. Don't worry. It will take some few days actually until you get used to this system. So don't worry about that. Right. So you can offer leaflets to this patient actually. Then you mentioned about referral to ear, nose, and throat. I would ask myself a question and say, so what am I doing here? Shall I offer treatment for this patient or not? It's a very important thing. I am a doctor. An FY2 is a doctor. An FY2 can treat, okay, can offer treatment for the patient. So what kind of medications I can offer to this patient who has tried over-the-counter Otrivin and tried antihistamine? And also I would ask you an extra question as that situation. Why didn't Otrivin or why didn't antihistamine did really work, or they did really work in the early beginning, what they didn't tend to work later on?
I think she's still exposed to the allergen, maybe.
Right. So, but why did it help in the early beginning, but later on they didn't really help?
I don't really know.
Okay, no, that's totally fine. So Otrivin, actually, if you do take it for more than it should be, I would say like 5 days. So at that time, this will help. This will cause like an vice versa kind of thing. So they get, yeah, resistance. Okay, like Dr. Clara is saying, which is absolutely fine. Mm-hmm. So it's a chemical reaction. It's a chemical reaction. So if the patient actually taking that for more than it should be, 5 days, 7 days, so what will happen is vice versa. Okay, so this sort of nasal drops, they actually are supposed to help with the symptoms, but if they do take them, what will happen is the opposite. The situation will get worse. All right, so that's why. The second question about the antihistamines, and me as a patient, I say antihistamines because it's a layman language. Every single one knows what antihistamines means, okay, in most of the cases, but don't use that. If the patient says antihistamines, it's fine. Most of them know what antihistamines are.
Yeah, because they are actually of the start. That's why I repeated the same, like.
Yeah, I mean, antihistamines are very common language here in UK, so because you can find them over the counter anywhere, so that's totally fine. But why is this patient actually, when she takes antihistamines, it doesn't really help? Maybe sinusitis. No, it's fine. I'm not like questioning you or something like that. Just trying to think out loud. Yeah, no, it's totally fine. Antihistamines are actually contraindicated in sinusitis because they make the secretions really very vivid, okay, very thick. So this actually makes the situation worse. She thinks that because she took the Otrivin, the nasal sprays, in addition to the antihistamines, so she thinks that both of them actually did really tend to help, but the Otrivin did really help in the early few days, but later on her situation got worse. All right. So what I'm saying is I should treat this patient if I can treat them. So what's the next step? The patient has been having this sort of symptoms for a few days, for a few weeks.
I should have asked how this is affecting her daily life. I forgot this, I think.
Yeah. We'll definitely speak about that. But I mean, in terms of the treatment itself, because this is the main thing for today. Have you steroid nasal spray? Perfect. Thanks very, very much, Dr. Emilia. Exactly. Emily,
yeah.
Steroid nasal sprays. No, it's absolutely fine. Absolutely fine. So nasal steroids are really very important. You can use them, and let's give them at least a couple of weeks time until you might find some improvement. Some people actually tend to find improvement on nasal sprays, nasal steroids, and actually even in a few days time. However, some people, and you will be surprised when you hear this, some people actually tend to feel some sort of improvement after 3 months time of the use of nasal steroids, okay? But make sure when you prescribe that you follow this patient up, the nasal steroids, okay? To make sure that their symptoms are improving, okay? Right, so did I mention about senior? Senior is a very important thing. You can also mention.
Yeah, I did. Yeah.
Exactly.
I told you about senior, yeah.
Yes, exactly. So senior is a very important one. Like I said, you are an FY2 doctor. And then let's speak about safety netting. Safety netting is a very important thing.
She gets like any fever, any discharge with like a weird smell, if there's any bleeding, she needs to come back.
Exactly.
You
All
need to
right.
have time, actually, yeah.
I know. That's why time management is a very important thing. And like I said, the data gathering was really very nice, but just omit the irrelevant things, and this will save your time in the exam. Okay, you will find extra time actually to speak about at least the safety netting. It's a very important thing. Never end any station without safety netting. That's the rule. Thank you. Then follow the patient up. Like I said, at least give them or give her a couple of weeks time just to make sure that their situation is actually getting better or getting worse. Like I said, sometimes the nasal steroids actually can take a long period of time until they feel some sort of improvement. But at least if their situation is stationary, is not getting worse, so that's reassuring on its own. Offer the patient follow-up, let's say a few weeks time, and see if they actually did really help. Then lifestyle advice. Lifestyle advice, I would give you a very golden tip about don't ever forget about a diary with anything that's actually could be triggered by anything. This patient, she told you that when you asked me actually, which was really nice, anything that seems to get it to bring this sort of thing on. I told you, no, but when you asked me, do you feel this symptom actually getting worse while you are at home, while you get out of your home? I told you, no, when I get out, that might be because of the cold weather. That can be a trigger factor. However, keep a diary. Ask the patient to keep a diary to document everything on every single day about what might be the things that actually makes it worse. The diaries actually can be kept up to 8 weeks time. I would say at least 8 weeks time, not up to, at least 8 weeks time, until you be able to identify all of the trigger factors. By identifying the trigger factors, this might actually help the patient to avoid them, and consequently to avoid this sort of problem from happening. What kind of things that actually can be triggered by triggers? I would say asthma, I would say seizures, I would say sinusitis, I would say hypoglycemia, right? A lot of things can actually be triggered by trigger factors. So a golden tip, headaches as well, yeah. A golden tip, which is always offer a diary with anything that actually can be triggered by any trigger factor. All right. So today we're speaking about the management plan, but you did really well, Dr. Iman. Thanks so much. We can speak about.
Thank you so much, Doctor, for the opportunity. Thank you so much. Oh, my exam is in 2 weeks. 2 weeks.
Oh,
just give me like quick tips.
No, it's absolutely fine. You were actually amazing, Dr. Iman. You will do really great in your exam. I hope. But just follow this minor tips and you will be all right. Don't worry at all. You'll pass your exam from first attempt. I hope so. No problem. Thanks so much. No problem. Right. So we have got one more station in here as well. If anyone actually is like to do it, that should be fine. I know that we might got some sort of being tired because it's a slightly long session so far. If anyone is actually happy to do it, I would be also happy to. If not, it's absolutely fine. If you've got any sort of questions, you can actually ask me at the moment, and then we will let you go. Anyone who is happy to do the station, just let me know. Otherwise, I'll just ask you if you've got any other sort of questions. And then until we meet again, I'll be looking forward to see you again very soon. Right. Any questions, doctors? Perfect. So thanks so much, great doctors, actually, for attending my session today. I hope you actually did really enjoy it. And please wait for the next sessions. They will be very interesting. You will gain a great benefit from them. I hope so. And also, if you're happy to let us know if you've got any sort of questions at all or anything, feel free to communicate with us. You speak to the mid-exam experts, actually, and this sort of email address, you can send them an email. You can follow up us on the group. If you've got any questions, I'll be more than happy to help you. If you've got also, if you'd like to join our one-to-one mock sessions, that would be also very good. You'll gain a great benefit from them, specifically for the doctors who have got their exam actually in the next few weeks' time. Will give you very golden tips. I hope you all best of luck and well done actually for the doctors who actually did participate today. Thanks so much, and I'll see you soon. All right, thank you. Take care. Bye.